All right, check that video out. What's up, everybody? I hope you guys are doing well. My name is Paul Singh. I'm the president of the Eye Centers of Racine and Kenosha out in southeastern Wisconsin, and truly honored and privileged to be hanging out with my good friend Justin Schweitzer from Vance Thompson Vision in Sioux Falls, South Dakota. What's up? How you doing, Justin?
Paul, great. Love the video. Of course, your work. Not surprised by that. I don't think anyone's going to be surprised by that, but super excited to be here with you.
See, I've learned early on in my career, if you can kind of like divert the attention to something else, then people don't really, it doesn't matter what you say. So that's why I resorted to those kind of like fun things. But no, but it's fun. Looking forward to having a great discussion on ocular surface disease and kind of how we deal with the optic nerve at the same time, man. It's a tough thing that we're dealing with every day, compliance and patient quality of life, and then the surface and what we do to it with all our glaucoma treatments. So we're gonna have some good times with that as well. So for the sake of time, I'm gonna kind of move us forward here for the next slide. These are your disclosures. You guys can read them, I'm sure, on your own, and a lot of good work you're doing with a lot of companies is great. And here's some of my disclosures as well. So I think it's both of us love working with industry, love to kind of keep moving forward and keeping us kind of on the next level there as well. But Justin, tell me about your thoughts here. I just feel like, to me, compliance is the biggest issue I face with medical management of glaucoma. It is so hard to keep people happy on medications long-term and dealing with this. I mean, is this a controlled glaucoma patient to you?
Nope. And he wasn't. This is a patient that I worked with one of our fellows a few years ago. And, he came in, nice gentleman. You can tell he's not happy with his eyes. He's uncomfortable, but he wouldn't tell you. But he was progressing. His fields were getting worse. But, he said he was taking his drops. But we'll miss him here and there. And we probably know why, right? When we just look at him.
Yeah, and that's such an important topic because, for many years when I'm old now, guys. So like, it's seriously, 18, 20 years ago when I came out of fellowship, as long as the impressions were good, bye-bye, see you later. I mean, yeah, you deal with people who are really, really bad, but a lot of red eyes, a lot of people with crusting and pain and redness and fluctuating vision. We were like, look, it's the best we can do, deal with it. But now my definition of controlled glaucoma and kind of where I think someone is controlled is not just pressure, it's really kind of tolerability and the likelihood of them staying on that current therapy for a long term. And I think that's because we have so many options, which we'll talk about. You feel the same way with you guys out there?
Yeah, 100%. I mean, I think you would agree, and a lot of people would agree that, this gentleman's probably suffering more from the surface issues and the issues with the way that his eyes look versus maybe how his glaucoma is affecting him. And I bet there's a lot of our patients that are that way out there if we don't address these things.
Absolutely, absolutely. And that's kind of why today is so important. And kind of what I've been noticing is my definition of glaucoma is not just fields and optic nerve and IOP, which of course still the heart and soul of how we define controlled glaucoma. But if someone, like I said here, like your patient comes in my office, I don't care how good the pressures have been. I don't care if the fields have been stable for the last 10 years. That's someone who's suffering. And so someone like this is one of my patients, kind of like what you were saying. They come in like that and crusting and irritated all day long. That is not controlled on my chart. And I'll think about something else, especially the ocular surface. What can I do to help that ocular surface? Because that patient is having complaints of suffering. And that is really why when we talk about glaucoma therapy and the ocular surface, we got to really understand what is the impact it's having on patients now, but also long-term quality of life and the ability for us to perform other glaucoma surgeries if the ocular surface is starting to get compromised.
I completely agree. And we know from a lot of different studies that you and I are going to jump into here that, glaucoma therapy can affect the ocular surface in different ways. And by no means do I want to sit here, and I'm sure you don't want to sit here and sit and bash the therapies we have, like topical drops. I mean, I utilize them every single day, all the time. But I think what we're going to try to talk about is how do you minimize some of that burden on these patients? And what are some treatment options to help with the ocular surface and glaucoma? And the other thing I think that's important when we think about this is the longevity that they've been on drops as well. You've said this many times when you and I have talked together is glaucoma is a marathon. It's not a sprint. And can we piece together different therapies throughout that marathon to maybe minimize how many drops they're on or how long they're on those drops? And I know you're going to jump into some things on MIGS and SLT. And that's kind of what I think I would like our attendees and other doctors listen to kind of get out of this talk today.
Absolutely. And what to dovetail off of that, it's that initial discussion you have with your patient, initial consult. It's important to recognize and important to educate them. Like, look, as you said, a marathon. And at any given point throughout the course of their disease, we're going to do what we think is best for them to control the glaucoma, as well as maintain the highest quality of life at that time. But it's important to recognize that it may not be one therapy. And so I tell them ahead of time, there might be multiple different options all over the course of your life that we're going to utilize to protect you, but also maintain the highest quality of life. And that's kind of that discussion early on that it helps kind of reframe and let them understand the context of the future.
So we look at some of these studies that I was kind of alluding to. We know that, the meibomian glands can be affected. And again, it's really the longevity, the amount of medications that may be on the eye. And this study points to that. When you look at table 3 there, we really have 3, or really it's 4 groups. We have group 1, but there's preservative-free drugs being used and preserved drugs being used. There's group 2, group 3. Group 2 is 2 medications, and group 3 is 3 medications. And what they did in this study is they looked at a quality of life, ocular surface disease index. They looked at tear breakup time. They looked at corneal staining. They looked at the meibomian glands. And what you see here is, number 1, the more drops that are being placed on the surface of the eye, the more symptomatic patients are. The tear breakup time declines. There's more corneal staining, and the meibomian glands are more affected. The other thing in group 1 that you look at is preservative versus preserved drugs, and we're gonna talk about that in here in a second, or non-preserved versus preserved. Is there is a difference there as well, not as significant as the number of medications, but another consideration for some of these patients, and we'll give you some ideas around that here in a little bit. This is just another study, again, kind of pointing to the fact that meibomian glands, ocular surface disease exists when patients are on medications for an extended period of time. This was published in 2012. These patients were on eye drops for about 8 years. And the significant findings were really, again, lid margin abnormalities, some punctate epithelial keratitis, gland dropout, decreased tear breakup time, and Schirmer's scores. And again, the more medications that the patient was on in this study, the more affected they were with those particular significant findings as well. And if we haven't driven the point home, one more study, and then we'll move on to some other fun stuff. Again, the number of medications, when you look at this particular study, that bottom point there, 1 BAK drop, 2 BAK drops, 3 BAK drops, the more BAK, the more symptomatic these patients are. So again, I like drops. I actually don't mind BAK either, because we know the medication's getting to where it's supposed to go. It's just how much can we minimize it and keep them on less to be able to still get the efficacy, but also protect the ocular surface in these patients as well.
Yeah, and it's important to also recognize that BAK, no doubt, is not your friend to the ocular surface over time. It is dose and time dependent, absolutely. But it's also the molecule itself. As you mentioned earlier, the prostaglandin analog itself does induce meibomian gland dysfunction changes, or meibomian gland changes rather, leading to dysfunction. It also does cause the loss of goblet cells. It actually affects the outflow system. So BAK and even the PGAs itself have been shown to cause that surface issue. So even if you take away the preservatives we'll talk about, the actual compound itself on the glaucoma medication is also doing some problems as well. So just taking away that alone, BAK alone is not the answer necessarily, which we'll talk more about as well. All right. So why should we care, Justin? Let's talk about that, because there's a lot of reasons why. And you mentioned earlier, I'm going to kind of skip to this. This is kind of the same idea you mentioned earlier. The more number of bottles that we add, the more risk we have of having a concomitant ocular surface disease. But why is that so important is because what happens in glaucoma? The first thing we learned as we're in residency and programs was you lose contrast. The earliest finding in glaucoma, if you look on the left there, basically the more advanced glaucoma you get, which is the kind of the yellow on the bottom, the loss of contrast, the less what we have is this is called a modular transfer function, how close the two objects have to be before we can see the difference. And you lose that. So night vision, colors, overall just contrast with daily functioning goes down significantly, even from mild to moderate. And you look on the right there, this is basically the same thing, looking at a modular transfer function, which is basically contrast in dry eye patients. And if you look here, the more dry eye you have, especially if it's centrally located, SPK, the more loss of contrast you have as well. And so the bottom line is, you marry the right chart and the left chart together, it's a double whammy. And so this is why quality of vision, quality of life, and there's actually studies out there that show us kind of just daily functionality, risk of falls, risk of car accidents goes down when you have glaucoma, and independently, if you have dry eye. You combine those two, that's kind of why it's such a scary thing to deal with as well. So I think it's really important to recognize the importance of addressing the surface. And, Justin, I'm not sure if you've heard from colleagues, but I've heard from colleagues a lot. Hey, man, I'm busy. I got 8,000 patients in my rooms, and I don't have time to even look for dry eye. I mean, just real quick, are you staining patients every day, or what are you doing just real quick to diagnose these patients?
Yeah, no, we go do speed questionnaire on every patient that comes in, any new patient that's coming in. So we get that to kind of identify it. And that kind of triggers my technicians to do a tear osmolarity as well as a MMP9 test. I don't do my mammography on every patient, but I'm looking, I have a philosophy that, every patient that walks through the door has dry until proven otherwise. And I don't care if that's a glaucoma patient, cataract patient, cornea patient, refractive patient. I use a lot of vital dyes. We're going to go through a very simple way in a little bit to look at diagnosing dry eye. I don't think you need all the bells and whistles, but yeah, I try to identify it in every patient if at all possible, and it doesn't take that long to do it. And we'll give you a little template here in a little bit on that.
Absolutely. And I just want to show this quick video here because, I use something called a Ratten filter, which is a kind of a yellow filter that you can place over your light source, or my actual slit lamp has a little filter built in. But the reason I want to put this is because you don't need to have to do a lot. This is the blue cobalt blue light, right? But look at that filter, what it does. It highlights that ocular surface so well. So this patient has EBMD, decreased till from breakup time, SPK. I would never really seen it. And even if you use fluoresce, which is a lot of volume, right? I put a fluoresce drop in the eye, then I talk to the patients, look at the chart, etc. By the time that I've done that speaking with the patient, talk to the patient, the fluorescence kind of washed away. Then I don't have as much of that. Then I can check the pressure again if I have to, or at least look at the ocular surface. So this is something you can buy even on Amazon for like $10. It's just a filter that goes over your the light source if you don't have it on your slit lamp itself. So it's something to think about, just a quick, easy way of looking at the ocular surface and the tear film, which is something that's helped me as well in my practice. But what really, oh, go ahead.
Just gonna say, love that video. That's impressive. Definitely, I underutilize it. Every time I do something like this with you, man, I figured out there's something I need to add to my armamentarium. So I need to add the Ratten filter.
Too, man. It goes both ways. It goes both ways, buddy. But that's what's helped me a great deal, because I've underestimated a lot of people. We think, like, why are they having dry eye symptoms? You look at that, you're like, oh, I missed it completely with my cobalt blue light. But the point, though, for me, what I've learned, and I think we see this now, is the fact that when you have patients who have dry eye, they have symptoms. And whether it's tearing, burning, pain, redness, photophobia, fluctuating vision, all that stuff, right? There's very few other conditions in the eye that have as many associated symptoms as dry eye. But what does that do is it affects compliance. And this is a study that from Boudouin who showed us that you have a 30% reduction of patient compliance if you have a concomitant ocular surface disease. So why should we care? Is if we're trying to stabilize IOP and we have data that shows more you fluctuate, the more risk of progression. Well, if you have a dry eye patient, they're likely not taking their glaucoma drops every day or even coming into their visits. And we have non-published studies showing us less accounts receivables, patients who less missed appointments when you treat their surface, because they're having less symptoms. They care about the symptoms, not about the pressure as well. So I'm not sure how you feel about that, but I can definitely see the correlation between dry eye and compliance clearly.
Yeah, I'm glad you brought this up, because we know that, and there's studies showing this. Nordstrom showed this. There's another study out there showing visual field progression in patients that have symptoms versus no symptoms. And we know if their eyes are burning or irritated, they're not going to probably take their drop, which equals progression. We don't have to necessarily, it's good to have studies, but you and I in a glaucoma practice see this every single day, that patients aren't taking their drops. So I'm really glad this is a great slide to kind of point to that.
No, absolutely. And as I mentioned earlier, if you look at data on VAK or even just dry eye disease, when you lose those goblet cells, the mucin layer is not as healthy, that conjunctiva is not the same. And so when you look at outcomes of trabeculectomies or any other bleb surgery like Zen or PreserFlow or others, it is affected. You get higher risk of fibrosis and failure. So even if you're thinking about long-term, what do we do, not just now, but in 5-10 years, if they need a subcon surgery, something to pay attention to now, because it can be an issue later on.
Well, awesome. So, we kind of did the review of the effect on the anatomy and the way that compliance matters. And I think we all would agree that those things matter, but that's great. But what can you do about it? You still have to treat the glaucoma. We know it's a vision threatening condition. And if we don't manage it and we don't treat it, people are going to have permanent vision loss or permanent parts of their vision loss. And so we could talk about this all day long, but if we don't talk about solutions, we're probably not solving the problem. And so we're going to spend a fair amount of time talking about what are some solutions and some things that, we both think about when we're managing patients like this, when they come into our practices. And I would say one thing would be preservative-free formulations. We have some options available out there, and we'll review a few of those. And preservative-free formulations are not my typical go-to, Paul, and I'll be curious on your thoughts as soon as I just review this study, but they're there for me. They're always in my back pocket. I'm aware of them. If I have a patient that has a cornea like the one you showed earlier, and there's someone that I still need on topical therapy, I definitely considered thinking about these preservative formulations. And this study did a really nice job of just showing patients that were on preserved medication. They then switched them to a preservative-free medication. And you could just see the percentage decline in not only patient symptomology, but also when you look at their ocular signs, whether it's conjunctival injections, SPK, palpebral signs like blepharitis as well. So I'll be curious, where does preservative-free fit in your kind of treatment armamentarium?
Yeah, no, it's a really good point. I think I'm kind of like you. I mean, I do know they're probably a better option for our patients long-term in general than doing preservatives for a long time. But I do tend to go to the typical preserved drops that we have available to us now. But I do agree, if you have someone who's coming in, having some issues, dry issues are getting worse, I definitely think that's a great first thing you can do is just, there's a lot of now options that we have, either BAK-free, that's not quite preservative-free, or preservative-free, right? Options that we have now, just not just the PGA, but there's companies that are making compounded pharmacies as well as others versions of these combination drops. So I think it's a worthwhile thing to think about if you're not sure why they're having symptoms of dry eye. It can help a little bit.
Yeah, perfect. You just led right into this. And that's exactly what, I think about too, the BAK-free latanoprost, the preservative-free options that are compounding. There was just a brand new FDA approved preservative-free latanoprost that we heard just before the holidays is coming to the market. So another option that we're going to have in our back pocket when we need to address some things with BAK-free or preservative-free options for our glaucoma patients. SLT, something that, I definitely think about on a daily basis. I know you do a ton of selective laser trabeculoplasty. I'm actually going to turn this section over to you to kind of discuss this. But, for me, if it's a first line patient, I offer them meds, but I always talk to them about SLT as well. I think it's my obligation and my job, someone that manages a lot of glaucoma as a eye care, professional, a doctor that's taking care of glaucoma, to offer them their options, even if they don't choose to do it, make recommendations. And this is something that's always on my mind. I know for you as well. So why don't you take us a little bit through SLT and how you kind of position this?
Yeah, I think, the one thing I've learned over time is the best way to avoid having glaucoma drops cause problems, just don't use them. And I'm not here to bash it like Justin said. I use them all the time. We need them. We do need drops, and we're happy to have all the chemicals that we have available to us. But I will say that offering SLT has really changed my practice, and we've had the Light trial, which we'll talk about, telling us and showing us that despite the same IOP effectiveness with drops, better patients have less chance of needing incisional surgery, less chance of progressing, et cetera. But SLT is the most physiologic to me way of approaching glaucoma. If we think, right, the trabecular meshwork is a primary source of resistance in about 50% of our patients with POAG, then why not address it directly? And what SLT is doing is selectively targeting the pigmented trabecular meshwork cells. So it's very little tissue destruction. So it leaves behind healthy tissue. It just releases what we call cytokines and interleukins. So your natural response. I tell patients all the time, this is rejuvenating the natural drain to help the fluid leave the eye better. Number two is it can be repeated. So let's say it doesn't do it up for, let's say, a year or two, we can repeat it again because it's non-destructive, and it doesn't limit the potential for us to utilize other, let's say, MIGS procedures that involve the conventional pathway as well. So I think there's such a positive, and very little, doesn't mean nothing bad can happen, but the adverse event profile is so low with SLT. Again, this is a Q-switch YAG laser that targets the trabecular meshwork cells. So unlike many years ago with argon laser trabeculoplasty, which was kind of a one-time thing, caused some laser burns, smaller spot size, you have a larger spot size, easier to perform the procedure. And again, it's just exciting the natural tissue. So the way I describe it to patients, Justin, is really, I don't use the word laser right away. And I don't say I'm gonna do a beam of, I'm just gonna say, look, your bottom line is your eye's like a water balloon. The fluid that's being made in the balloon is not leaving the balloon. So the balloon's getting tighter. We have to help your natural drain release the fluid. What we're doing is with a beam of light, we're naturally exciting your tissues to rejuvenate it, to open itself up naturally. And if it doesn't work, we can try drops. If it does work, then we can avoid drops for a period of time, and we can repeat it if necessary. It's covered by insurance. It takes about a minute to do in the office. What do you think? And so that's kind of my spiel. And I think the confidence of which you prescribe or you describe it to patients really does help them feel more comfortable offering it as well. And so I think the fact that it's non-destructive, leaves behind no scar tissue, really does help me feel more comfortable that it's, hey, if it doesn't work, I also can tell me where's the resistance to outflow. If we think the primary source of resistance at the TM and SLT doesn't work, what does that tell you? that there might be some resistance beyond the TM. Maybe the canal behind it's collapsed, or the collector channels are not functioning. So if I have a patient who, let's say, doesn't have success with an SLT, like we said, about 85% of the time it has success, those 15 to 20% of patients who do not respond, maybe the resistance is beyond the TM, and that would tell me when I'm doing MIGS, do some canal-based canal dilation procedure or something else as well. So it helps you, I think, in terms for me, understand where the resistance to outflow is. And really, Justin, I'd love to hear your thoughts on this and how this affected you. But the light trial, I think, even though SLT has been around well before the light trial, we have had a number of other studies looking at SLT for decade plus. I think this trial really helped kind of solidify and re-energize a lot of the excitement around SLT to get as a first line treatment, not just down the road after you've tried drops for 3, 4, 5, 10 years, but as a first line therapy. And I'd love to hear your thoughts before I talk so much more. But what did the light trial do for you to give you some confidence that this may be a good option first line?
I love listening to you talk, man. You can keep going all you want.
Dude, man, I can talk forever.
thanks for letting me jump in. No, I completely agree with everything you said. I think point one, the fact that you don't say laser, I think that's great. I've also taken that from you as well, because it brings comfort to patients. So I'm glad you brought that up. The light study, now that we have the 3-year data, which you're looking at here, we now have actually some 6-year data on it as well, showing that, patients are drop free. That high percentage of time, the last bullet point, is really what brought me a ton of comfort around it. Almost 80% at 3 years, drop free in the light study. It just makes it easy for me to have a conversation with patients about it.
Oh, absolutely. And yeah, you're right. 6-year data confirms the same thing. Less patients had visual progression, less patients needed cataract surgery, less patients needed incisional surgery compared to the drop arm. Now, in the SLT arm, there were some patients who had multiple treatments, and it was true. But the key, I think, factor is that the IOPs between the two groups were exactly the same. So drops versus SLT, no difference in IOP. The only difference was in the SLT group, less patients were on topical drops, and the theoretical chance that you're probably having better 24-hour IOP control because less potential for fluctuating IOPs. So there's no doubt that this study kind of showed us that drops are a risk factor for progression. I think that was really what kind of blew my mind with the light trial, just kind of really elicited that and made it very clear. And this is just an example of a pre and post SLT, using my Ratten filter again, just before and after, showing you with one topical PGA after 6 weeks, what kind of impact it has on the ocular surface by just getting rid of that one topical drop as well. So we kind of minimize, big deal, what's one drop? It can make a big difference. This patient had nothing else added to them, no additional cyclosporin or lid scrubs, just take out the drop, see what happens in 6 weeks, and that was the surface as well. So it can really have a significant impact on the ocular surface, just getting rid of that one drop if we can.
Boy, drug delivery, what an exciting area. I think, sometimes I get asked at a meeting, or I'm lecturing from the podium, what are you most excited about with treatment in glaucoma? And, I love co-managing and managing MIGS. I work with a glaucoma specialist, as you know, Paul, and I love being able to do that piece of it and help patients in that way. But boy, drug delivery is an exciting arena for a couple of reasons, compliance issues that we talked about, but the other thing just being that the ocular surface piece of things. And so I kind of just highlighted everything that's being looked at. There's a lot being looked at, and we're going to talk a little bit about a system that we're both using in our practices that, for me at least, and I think you would agree, which is Bimatoprost SR, has really become a treatment for, yes, lowering IOP, but even more importantly, helping my patients with ocular surface disease. So I treat it using it, kind of give patients a drop holiday. So I'd love to get your thoughts on that here too, when we kind of get into the video of it being done and kind of the way that you utilize it in your practice. So for many that are not familiar with Bimatoprost SR, this is a glaucoma drug delivery device that's on the market. It's a 10 microgram sustained release implant. That really doesn't need to be done in the operating room. It's quite often done in the exam room and in your clinics. It does over time biodegrade. So once it's implanted, you don't have to remove it. It elutes medication for about 4 months, but we'll touch on that a little bit. I always like to say that even though it's eluting medication for 4 months, don't let that fool you into that it's only efficacious for 4 months. A lot of times it's more efficacious than that. It is FDA approved for anyone with primary open angle glaucoma. So an open angle can be used in exfoliative glaucoma, pigmentary glaucoma, as long as the angle's open. And right now, if there is a downside to it, we can only do one of these. That's just how it's approved, but it still serves a really important purpose, I think, when we think about managing our glaucoma patients. So, Paul, I'm going to hit the video. Would you mind just kind of taking us through the procedure? Because this is done in the clinic. I know you do it very similarly in the clinic in a patient here at the Slit lamp.
Yeah, no, I mean, this is a great video. Thanks for sharing your video here. But yeah, I think the key is you want to have the patient kind of stare at one spot on the slit lamp so they can keep their eyes still. I do anesthetize both eyes, even if I'm only doing one eye, so they don't blink or get or squeeze. I don't use a speculum like you do because I think it does get in the way. And like you're doing here, I rest my fingers on the cheek, my 3 or 4 fingers on the cheeks, that way it stabilizes. Enter through the clear cornea, just anterior to the limbus. Go straight parallel to the iris into the anterior chamber till you're about 2 bevel lengths into the anterior chamber. And you press, there's a button there. You press the back part of the button, press it with distinction, with conviction. That way it comes out, because sometimes it can get stuck to the needle tip there. And then you did great, just come straight back out there. That's really important because you don't want to kind of come out tangentially where it could cause some egress of aqueous out of the wound, and that can cause the implant to kind of come with it as well. But in general, it is that straightforward. It's like an anterior chamber tap, an AC tap. And so what's so nice about this is that it is, as you mentioned, done in the office. So patients don't feel this risk of having to go to an ASC, et cetera. And you can still do it on ASC as well if you need to. But I've had patients, Justin, honestly tell me that was easier than getting their eye pressures checked with an applanator, with an appellation tonometry, because there's nothing coming at them like a big blue light. It's all from the side. Just tell them to look at the straight ahead of the slit lamp. You may have some, you tell me, you may feel some pressure for about 5 seconds, and then they come out. So the patient experience being so positive and so comfortable, their expectation of it lasting forever is not a big deal. And that's why I think a lot of our colleagues, I'd love to get your thoughts, they're kind of worried about this whole single administration approval. Okay, it can all be done for one time. And if it lasts 4, 6, 8 months, a year, depending on how long it lasts, people are wondering, well, what do I do if it wears off? I have not once had a patient yet when it needed to be, let's say, wore off and needed something else done. Not a single patient got mad at me for having to do something else when it wore off. I'm not sure if you've had that same experience, but I don't get too caught up with the whole single administration concern. Even though I'd like to have more administrations, I still feel there's a value to that.
Completely agree. I 100%. I've never had a patient upset about it. My mindset, again, I've said it earlier, and like you too, glaucoma is a marathon. These are great treatment options. If I can give a patient a break from a drop for a little while to manage their ocular surface with some things we're going to talk about in a little bit, that's a win. Whether it's 4 months, 6 months, a year, 2 years, we found out from this particular study, the phase 1 and 2, that even though it's a eluting medication for 4 months, I want you to look at that bottom point there. The rescue or retreatment, 68% of patients in the 10 microgram group or so went 6 months, 40% went 12 months, and 28% went 24 months without needing to be rescued. And so there are patients that you will see that will not need to be rescued for 6 months, for a year, for 2 years. And I can attest to this in my clinic that I do have patients that are a year out from this. And we've probably done north of 300 of these or so that get 12 months, that maybe get 24, but I have plenty that only get 6. And again, none of those patients have ever said, boy, I didn't want that. Have your experiences been similar with it, Paul?
Yeah, absolutely. In fact, I think we have, I'm not sure if my data slides here or not, but we have, I think 70% of our patients are, I think 9 months, I believe. We have almost 50% at 12 months as well. So I think we have a significant responses kind of like this as well. And I tell patients all the time, I tell them, look, we don't know how long it's going to last. I think just for everyone out there, what we think is happening is there's a change in the metalloproteinase, the release of MMPs. And by having a 24-hour release of medicine in the eye, we think we're actually modifying the natural progression of the disease by changing the actual levels of what we call MMPs and the tissue inhibitor of MMPs. MMPs release macrophages and cytokines to open up the TM, kind of like SLT. So by having that 24 hours a day, we think we're remodeling the ciliary body and even the TM, because the receptors are in the trabecular meshwork as well. And that's what makes it so unique and so exciting, and why we think there is that longevity or duration of effect compared to a topical medication as well. So yeah, I see the same kind of results in our practice.
So let's jump in a little bit to ocular surface disease and minimally invasive glaucoma surgery. I know, again, something you had mentioned earlier, you do a fair amount. And I think I brought this up mainly not to go through every MIGS procedure, but number one, we talk about the number of medications. And when you look at all the different studies out there, whether it be, the HydroStent, the iStent inject, another, procedure over here called Omni, we're seeing a reduction in medication usage as well as lowering IOP. So how often do you think of MIGS as a treatment for dry eye in your practice, Paul?
Actually, all the time now. I mean, I truly can say that, not just around cataract surgery. I mean, for me, it's a no-brainer. If you have a cataract, you're on glaucoma drops. It's just, to me, it's 100%. Everyone's going to get some type of MIGS, whatever it is. But now, even on those patients who, let's say, are phakic, or even those patients who are pseudophakic, had cataract surgery many years ago, and they're having significant ocular surface disease, I'll think about SLT first, do Durysta, drug delivery, like we talked about. But I have a low threshold now to consider. In fact, I did 3 Infinites, which are standalone stents that I just got approved just yesterday. So I'm doing all these different devices because I do think part of our definition of success of MIGS is not just the absolute reduction of medication, reduction of IOP. It's what is a medication burden reduction. Example, you have a patient on a PGA whose pressure is 14 on that PGA. You do your MIGS of choice, they come back and let's say even at 3 months, their pressure is 16. So 2 points higher, but they're off the PGA. I am still happy with that. That is significant success because I took that patient off that medication, and I have more confidence of a patient pressure of 16 off of meds than 14 or 15 or 16 are going up and down as well. So to me, Justin, yes, this is a big, significant reason to do MIGS for me, but also my definition of success is not just IOP reduction, it's the medication burden reduction like you're showing here.
I think that's such an important point because we get caught up in lowering IOP, but that's not always the case. And there's the quality of life aspects of it, which is what we're going to dive into next here. And I'm going to share a study, and then you're going to share a study as well. But this was a small pilot study that I actually did at my center with a good colleague, Dr. Whitney Hauser, and she did it at her center. And then with our surgeons, John Berdahl and my partner, OD Mitch Eibach. And really what we wanted to do here was just look at patients that underwent cataract surgery plus a MIGS procedure. And in this particular case, it was 1 stent or 2 stents. So there was a mix of these. There were 50 patients. We had them take an OSDI on the front end. And then 3 months post-operative, we had them take the OSDI as well. And we looked at tear breakup time. We looked at corneal conjunctival staining. We looked at, hyperemia. And completely honest, Paul, this isn't a study that's going to blow anyone away. It's just no one had ever looked at it really in this aspect. And so we said, well, why don't we do it? What we really need now is a study that's 2 years, 5 years, 10 years, a longer study to look at the quality of life and the aspects of this. And I know you're going to touch on one here in a little bit. So these patients, when you talk about IOP lowering, these patients were on, 1.5 glaucoma medications. That was what the average medication usage was. At 3 months, they were down to about a half a medication. And when you look at the results here at pre and post-op, this was the OSDI index, 40.1 preoperatively, which is in the severe level of the OSDI. At 3 months, it was down to 17.4. Now, wow. Still in the mild, not completely 100%, but a big drop from 40.1 down to, 17.4. When we look at corneal staining, we saw a 3-fold decrease in corneal staining going from 1.4 to 0.4. Very similar to your beautiful image looking at, SLT and that image. When we look at tear breakup time, we saw a 35% longer tear breakup time from preoperatively to that 3 months. And with all of that, we looked at some other things too, but those were the main take homes from the study is with less medication, with cataract surgery plus a MIGS, we were able to make patients less symptomatic, better corneas, less redness, and, just overall happier patients. And again, only being a 3-month study and only 50 eyes, what can we take from that? Maybe not a lot, but it fits a lot along the lines of what you're going to talk about next with a much larger study that was done than what we did at 50 eyes.
No, but what you did was fantastic work and much needed work. And we just basically dovetail off of that as well. Oops, go back up there. This is a publication with Tom Samuelson and Blake Williamson and others. And this is based upon the phase 3 trials of the iStent inject. And in the phase 3 trials, we actually asked patients to fill out a VFQ-25, which is a questionnaire for quality of life, and OSDI scores, the Ocular Surface Disease Index score for dry eye as well. And we looked at his patient-reported outcomes. What was the improvement in patient-reported outcomes? Now, this is cataract surgery alone versus cataract surgery with the iStent inject. And this, again, the phase 3 trial, so randomized controlled trial, multi-centered trial. And this is looking at the 2-year follow-up. And what we found is in the orange is the cataract stent and the gray is the cataract alone. And if you look at the VFQ-25, the questionnaire for quality of life, as well as the OSDI scores on the left there, you see a significant improvement. So these are patients who had improvement in their patient-reported outcomes as well. So significant difference with the cataract stent. On the right, though, is really looking at the patients who are actually medication-free. And you see, if you took the patients who are medication-free, they had the greatest improvement in their quality of life or the patient-reported outcomes than those who on the gray who were on medications as well. So no doubt there was a correlation, direct correlation between patients who were doing better and happier and had less dry eye and those who were on or off medications. Looking specifically at the VFQ-25 questionnaire, looking at things like driving, ocular pain, general vision, general health, orange is the cataract stent, gray is the cataract alone, you see a significant difference, again, just showing you the breakdown. So now we actually have real good evidence, published data, phase 3 trial data that now can tell us all that, yeah, doing a stent or doing some other MIGS at the time of cataract surgery, at least, getting them off the medications can improve or give them a better risk or better chance, rather, of having an improved quality of life after the cataract surgery. So this is, I think, a study for me that really helped me tell patients, yes, I can improve your quality of life better if I do this MIGS procedure at the time of cataract surgery.
And I love that data is coming out, because you think about it, we know MIGS lowers pressure. We know that MIGS help to, decrease the amount of medication usage. And now you have the quality of life piece. It's, all those 3 things are so huge for our patients. So we have about, 5 to 7 minutes left, Paul. I'm going to cruise through some additional treatment considerations around this. Oral medications. So when I think of this, I really think of something like, doxycycline, using something, because I think of that because I don't want to burden my patient with more drops. And, there was recently, and I don't know if you saw this, a poster that came out at the American Academy of Optometry meeting by a group of doctors from ICO. And it was interesting. They put patients on oral doxycycline, and it was looking at adjunct IOP lowering with this. And fascinating, Paul. So what they did is they had them on 50 milligrams of doxycycline for 90 days. They had these patients, they were already on their normal glaucoma topical medications. And then they followed them and looked at them at 30 days, 90 days, and 180 days. And they checked their pressure. And interestingly enough, with no changes in the topical medications, just the oral doxycycline, at 30 days, there was an 8% reduction from their baseline pressure. And their baseline pressure was about 16 millimeters of mercury. That was the mean IOP, so fairly low pressure on medications. At 90 days, there was a 15% reduction in IOP. And then at 180 days, when they had them off the doxycycline, it was only about a 4% reduction. So of course that it went up a bit. I shouldn't say of course, but that's what happened. So really interesting. And I know they're going to continue to look at this. When I think of doxycycline, I think about for treating dryness. That's how I use it, or treating MGD. But they presented this poster looking at it as an adjunct therapy for IOP lowering.
I love it. I love it. I know we don't have too much time, but I'll tell you why I think that's happening. Number one is we do know that we're increasing inflammation on the surface of the eye when you have ocular surface disease, and you can get a trabeculitis of some sort. So I do think what's happening when you're treating doxycycline, you have better lipid layer, you have less inflammation on the surface of the eye. I do think there's probably less trabeculitis, probably even in the collector channels as well. Second thing, I think compliance. If they're on drops and their eyes are feeling better, less MGD, less dry eye symptoms, et cetera, you're probably increasing compliance issues. But I do agree, there's something to it. And we've seen it in our practice too. That's a fantastic study. I didn't really get a chance to read it, but thank you for bringing that up to everybody. That was a great study.
I love I love you added to it there with the reasoning behind it. I think that matters, and didn't think of it that way. So thanks for bringing that up about what's happening in the trabecular mesh work, those 2 points. And that's very logical and probably the reason. You're exactly right that that's happening. Nutraceuticals, I'm a fan of nutraceuticals. We think about the DREAM study and some of the controversy around that, but I'm still someone that uses a lot of nutraceuticals, even in my glaucoma patients. I'm a fan of a substance called GLA, obviously EPA, DHA. So I still definitely utilize nutraceuticals. Paul, are you a nutraceutical guy? Do you use them a fair amount still in your practice?
There's a number of different products out there as well that I use, but I think it's worthwhile. I think it depends on what you're using. And that's the key. Some of the studies that we're not looking at the right compounds and the right molecules. So I think with the right molecules, the right products, it does make a difference in my hands.
My quick pitch to everyone that's listening to us about you got to treat dry and you can do it. You don't need every bell and whistle under the sun. You need 4 things, in my opinion. I like a speed questionnaire of some sort because you can identify your patients. You need a slit lamp, which we all have. You showed it already. You need some fluorescein dye, some vital dyes, and a Ratten filter. I'm going to add that in at some point.
I love it.
And you need a finger or a thumb so you can analyze the meibomian glands. And if you have these 4 things, in my opinion, you can manage dry eye and you can take care of patients, and you're going to be able to identify it. You look, lift, pull, push, and have the patient look down so that you can identify something like Demodex blepharitis. And I'm telling you, you could treat a lot of dry eye. I don't care if it's in your glaucoma patients, which is what we're talking about, or any type of patients. Those are the real things you need. And all the other stuff is nice, but you can do it with these types of things.
Yeah, I mean, those are 2 pictures I just took not too long ago. Ever since I'm realizing there's something coming out soon for Demodex, I started looking patients. I had to look down, and it's scary how many people have these mites on their lids. It's really kind of frightening. So have a look down. It's all you got to do, and you can see it pretty clearly.
Completely agree. I've started to do that a lot too. And man, there's a ton out there, right?
No doubt.
In-office therapy is just some other treatment options. Again, not to treat glaucoma, of course. We're thinking about, treating MGD, ocular surface disease. There's thermal pulsation treatments, something that we definitely utilize in our practice. There's devices that actually can heat the eyelids, and then you express or clear out the glands. The Olympia study is the study that kind of shed some light on these 2 studies, these 2 products or these 2 technologies, put them head to head. And what you're really going to see with this is that both of them do a heck of a job. Both of them do a great job of managing ocular surface disease, managing meibomian gland dysfunction. You can see tear breakup time being improved in both groups. The blue and the red are the 2 technologies that we just talked about. And this is just showing that improvement in the tear breakup time with both those technologies. They also looked at meibomian gland secretion scores. Again, improvement in that as well. There's a 3rd technology out there where it's a little smaller footprint. You actually control the amount of pressure that you're placing on the glands. It's, again, expressing the glands. You got a little magnifying glass where you can have that great feeling of being able to look at that meibum, that gooey stuff coming out. Some people love that. I actually enjoy looking at it when it's come out. I'm feeling like I'm helping my patients. And this is another study just comparing the 2 thermal pulsation procedures out there. And again, what you're seeing here is improvement in OSDI, improvement in tear breakup time, improvement in meibomian gland secretion score. So I'm a fan of these technologies, and I do utilize them on a daily basis. I utilize them in my glaucoma patients because, again, a lot of these patients have MGD. Do you utilize any of those technologies, Paul?
We do. Yeah, we do the heating. We do tear care in our practice as well, and I think it makes a lot of difference. So we're starting IPL soon, which we're going to talk about, and I think even those, there's other nasal sprays we can talk about, varenicline, and there's even cyclosporin and lifitegrast. Don't forget those. Even if you take them off the glaucoma drops, remember our population of patients who have dry eye and glaucoma tend to be ones who have dry eye risk factors in general. So treating with those other topical medications are also important.
Agree. IPL's made a huge push. I mean, more and more studies coming out. I think I looked at a paper one time, like in 2016, there were like 3 publications out about IPL. And then in like 2019, 2020, there's like 26, and there's more now. So this is something that's being well studied, well published. Maybe the mechanism isn't quite well understood, but we know there's therapeutic effects. And I'm not going to spend a lot of time because I want to wrap up on this, but this is one of those paper that's out there in my practice. A lot of times what I'm doing is we'll do a thermal pulsation treatment, or we'll heat the glands and I'll express it. And then we'll do between, 2 to 4 weeks, we'll do 4 treatments of IPL. So we'll do a treatment of IPL. And remember, this is light. We actually do a BBL, which is another type of light that we use on the lids. And we'll do we'll express the glands. We'll then do a BBL or an IPL. We'll wait about 2 to 4 weeks. We'll do another one. Wait about 2 to 4 weeks. We'll do another, and then we do a 4th one. So we do 4 treatments. And I've been blown away with the results, how much it's helped patients. And a big fan. And it sounds like you're going to be jumping into that arena as well very soon.
Absolutely. No, I think there's definitely a role for that as well, especially when you look at those glands, those telangiectatic vessels, and look angry. This can really make a big difference for those patients.
Well, Paul,
wow. We got through everything. Are you serious?
Yeah, we're there, man.
Man.
I just want to thank you, bud. I mean, and
we stayed on time.
I think we're right on time too. We'll be able to take some questions, which will be fun. Just appreciate awesome. Always having the opportunity to do these things with you. And again, I learned something like always. And just keep in mind, everyone, that, ocular surface disease is prevalent in all patient populations, but we see it a lot in glaucoma as well. And it's easy to get caught up in thinking, boy, I can't let that patient lose their sight, or I got to get their pressure down. And yes, that's important. But remember, there's the quality of life. There's the things that patients are struggling with on a daily basis with how their eyes look, and how their eyes are feel. And so I encourage everyone that's listening to us today to, attack the ocular surface as much as you're attacking, trying to preserve the optic nerve head.
Well said. Not much more to add, but thank you, Justin. You're awesome to listen to. I learn from you every time as well. Keep up the fantastic work. And thank you, everybody, for listening to us. Love to answer all the questions hopefully you have.
Welcome back, everybody. And thank you so much, Justin and Paul, for being a part of our program. Two of my favorite people. I love having you guys on board, and I learn a great deal from you every time. We have 5 minutes. So I want to use this precious time as much as we can. Justin, one of the things that we've seen is a transition in how we take care of our glaucoma and ocular surface disease patients. Certainly a lot more in the MIGS, procedures versus TRABs, in the last 4 or 5 years. And also some of the other things we see is other alternatives to drops. So I was just wondering if you wanted to kind of take that on and let me know how has that been going in your practice, and what is your approach?
Yeah, sure. I think that there has been a shift in the way that we treat our glaucoma patients. And I think it's important that we pay attention to what's happening with the ocular surfaces as well as what's happening to their visual field OCT. And we have some new tools. I mean, I still love drops. I use them all the time, but Paul mentioned it in our talk about the light study. We have SLT that can help minimize drops. We have Bimatoprost SR. We have an implant that we can minimize drops, MIGS procedures. And so I think we have to think about that, because our patients won't always tell us that they're suffering from an ocular surface disease standpoint. They'll live with that because they trust their doctor to do what's best for them. And I would argue that a lot of our patients are suffering more from probably ocular surface disease issues than they are truly from that small visual field defect or nasal step that's occurring.
Awesome. And Paul, I just love the way that you framed what is their new definition of a well-controlled glaucoma patient. What are patients won't really kind of sometimes tell us that they're really struggling. So what is your advice on how to really balance this, carefully, and how do you communicate that with your patients these days?
I think this great question, great point. I think the key is allow them the opportunity to be honest about not being compliant. I always say, assume they're guilty in a very loving way. So, look, Mrs. Smith, I know you're not taking your medication. That's okay. Let's talk about it. And the key, the way I do it is look for clues of non-compliance. If they're coming back and they can't remember the name or the color of the top of the drop, and they've been taking it for 10 years, not good. If they come in and say, hey, do you have a sample every time they come in? They run out every time. That's probably they're either not taking it or they're not using it, or they just can't afford it, right? So if a patient is complaining of fluctuating vision, think about dry eye. So I always just kind of frame it in the sense of pick on a compliance issue that you can pick up, cost, side effects, and then tee off of that and say, look, I know cost is an issue, isn't it, right? Let's talk about that. Right? And so not just saying, oh, you're fine, your pressure's good, I don't care if your cost is too much, we'll see you back in 3 or 4 months. Addressing it and saying, look, we have other options if we need to, and being aware of the options. That is, to me, the biggest balance. It's just not assuming that maximum tolerated medical therapy has to be 5 medications or 5 drops. Maximum tolerated medical therapy could be 1 bottle, depending on how they can take care of that level of compliance issues.
Perfect. Awesome. Yeah. One of the things that I think is fairly new, and maybe we've had some data on it, and it's just kind of being reevaluated these days from a new study that linked doxycycline with pressure lowering effect. And so my knee-jerk reaction to that, and I was kind of talking to Justin too, is like, oh yeah, well, it makes sense. I mean, if you're decreasing the inflammation on the surface, they're more compliant, therefore their glaucoma is also going to have a better outcome. Do you think there's anything else to that as far as anti-inflammatory effect on the trabecular meshwork? And what are your general thoughts and your general reaction to that?
I would say, yeah, I think there's no doubt there's something more physiological going on underneath. Yes, compliance, patients are feeling better, less issues with the surface issues, directly correlates to higher compliance. But I think there is no doubt data that supports when you have ocular surface disease inflammation, it does affect goblet cells, it affects the trabecular meshwork, affects the actual collector channels. So I do think there's level of mild trabeculitis that is going on, that when we do the doxycycline, we calm that inflammatory cascade, you do maybe are opening up the TM out at ECM and helping flow. So I think there's something to that. I think we're going to see more and more data coming out. Absolutely. Justin, what are your thoughts?
Yeah, no, I agree. I mean, when I first saw the study, I agreed with you, Ahmad. I said, this is just decreasing ocular surface disease inflammation. Now my patient feels better and I'm going to take my drops. But there's more to it. And as we see more of this, I completely agree with Dr. Singh on this, Paul, with this, this decrease in anti-inflammatory effects in the TM is probably allowing that 25 to 35% that we saw in the study that you're alluding to, Ahmad, and that we talked about earlier.
Awesome. Thank you guys so much. I mean, I could sit here and talk to you guys for another half hour about this. I really appreciate you being a part of this. I appreciate your time. Thank you so much for being with us.
Thanks, guys. Have a great
Thank
day.
you.
Great night. Great weekend, everyone. Thank you.